In the house, it's Dr. Dan Edney, State Health Officer. Good morning, my friend. How are you?
I am well. Good morning, Paul. How are you?
It's always busy here. Fatigue setting in as far as the legislature. I know this is 4 months, but gosh, it feels like 6.
Oh, Lord, fatigue set in about 6 weeks ago.
Yes. And I can imagine what it's like for these guys and gals, especially the first year. They go and say, how in the world can I even do this? Just take 4 months out of my business or job and do this. Did I make a mistake? I'm hoping they don't think that. But it has been rather interesting. Your comments on the death of Medicaid.
Well, it's interesting that you started the show off today with the colonoscopy song.
You were up early, weren't you?
Brother,
Tim Hawkins was
brother. I'm up early every day.
Yeah, well,
but the colonoscopies save lives. It saved my life, and but you got to have insurance, man. You got to have insurance for
because when you start dishing that out on cash, you're talking about a couple of thousand or more.
Low income folks can't do that. My daddy couldn't do that.
Nope.
And he died of colon cancer at 54. I'm alive today because I have insurance. So we've got to get to the right answer for Mississippi. I think we all agree. My message this year was, can we not agree that we have a problem? As an addiction doctor, that step one is admit we have a problem. And then once we do that, we can all move together to find the right solutions. And they worked hard, got very, very close. And, in 6 months, North Carolina took 4 years to get where they got to last year. So they worked really hard at the Capitol this year, and in 6 months went from 0 to 95, very, very close.
I agree with you. I think some of the just to get to where we weren't talking about, just to talk about it,
right.
It's like having a married couple at least go through therapy. But then you hear the words of the lieutenant governor said, well, next year it's going to be the first thing we take up. Well, that's fine. What's going to be different other than if there's a new person in the White House, certainly from the Republican Party, who would acquiesce the work requirements without any problem. And
I would say, looking at it objectively, both chambers brought to the table really good ideas, and I wouldn't poo-poo what was brought forward with the work requirement with those exceptions. Nobody else has looked at the work requirement the way our legislature did this year. And so everybody's saying that it's absolutely dead on arrival. I respectfully disagree. I think when you present what was brought forward, it made an awful lot of sense to a lot of people and covered 95% of folks in the coverage gap, even with the work requirement. Those were very generous exceptions, and I think everybody needs to look hard.
Doc, let me ask you this, because from the very start of talking about work requirements in the very first bill to its evolution till Thursday, a deadline, there was even a lot of flexibility that wound up in the work requirements, was it not?
Absolutely, and I think both chambers compromised and worked hard to get together. Just didn't quite get there, but that's not uncommon with really complex policy, especially in healthcare. So, I'm disappointed but not discouraged. The people we serve at the health departments, we're looking at 42% uninsured. So I desperately need something to close that gap so I can have funding to keep our county health departments going. Yeah. And I've been running a free clinic for 25 years in Vicksburg, as you know, and that's low-income working class folks, and they need better than free clinics. They need real medical homes.
I hate to get to, and I mention this all the time because of our get-togethers here, the importance of the community health centers. And I was just thinking, if you look at some of the worst parts of this is how could that money have been used? We're talking about the amount of money that was going to come in on this. Did you have some of this earmarked for that?
Well, I wasn't anywhere close to earmarking anything. Yeah. But talking to my colleagues.
Let me say dreaming about it.
Dreamcasting, yes.
Yeah.
And that came from talking to my colleagues in other Republican expansion states where they're telling me that they're filling the gaps with mental health funding in very real ways and public health funding in very real ways that they just weren't able to do before. There are a lot of resources that come with the Affordable Care Act that are a huge benefit to public health and mental health that are outside of just providing insurance to low-income folks. So there are a lot of benefits that just need to be thoughtfully looked at, and let's decide together as a community of Mississippians what's best for us. And I think more importantly, what's best for our folks that are working really hard every day and just need a helping hand.
When you talk about changing the culture, because that's the only thing that's going to change some of these statistics, low birth weight rates, infant mortality, STDs, and things such as that. And there's a culture there, just much as it was the culture of our fathers trying to get them to go to the doctor. It's just something that they didn't want to do. So it's how would that money change that culture? That's the problem. How do you get these young folks to understand about venereal diseases and things such as that, and to use more protection?
Yeah, now understand the syphilis issue. We had syphilis whipped back in the 90s, but we've made decisions in this
What was the difference then?
We were funding public health back then, and we had plenty of disease investigative specialists out in the field finding these cases and getting them treated and closing the loop. But look, you get what you pay for, and you invest in what you care about. And we have chosen since 2017 to underfund public health at the state level, on top of the federal budget underfunding it at the national level. So we're where we are with syphilis, not because of change in culture, but because of change in funding and our inability to attack core public health services that we did forever. We had syphilis whipped, and now we're having to get our arms back around it again, and we are moving the needle on syphilis, but just through elbow grease. And I'm proud that we got a little bit more funding that I'm going to deploy into that space. But this is really important, Paul. Look, you and I are both Mississippians. You and I could do better with our health. I think we both could agree with that. But folks in Alabama are no more responsible with their health than Mississippians. In Arkansas and Louisiana and Tennessee, their outcomes are much better than ours. But they invest a lot more in public health, by orders of magnitude more at the state level. Alabama is investing 3 times into public health what we are. And so their county health departments are much healthier than ours are. But we can change these numbers through education, through culture change. And our obesity rates have gone down the last 5 years. There's some culture change happening. But we have to get Mississippians in primary care medical homes for us to reduce cardiovascular deaths and cancer deaths. We have to. They have to be in front of a primary care provider, educating them, diagnosing their diabetes, hypertension, hyperlipidemia early, instead of when they're so sick after they had their heart attack or their stroke. We can do better with primary care in our state.
Let me ask you this, because I don't know, I'm just inquisitive about this. Is there a competitiveness in the markets where there is a community hospital and a health care center?
There is no competitiveness between our county health departments and the private sector.
There's two different services.
And there's three. There's 4 different services. You have private clinics, and then you have FQHCs, which are really the community health clinics. Then you have the county health departments, and then you have free clinics. And we all have to work together, but the health department is the provider of last resort. We don't compete with anybody. No. God love us, we don't have the resources to compete.
I got to ask you this. What part do you think the Democrat caucus played in throwing a wrench into this thing when we come back with Dr. Dan Edney? Right after this, Leah Long is going to join us, National Federation of Independent Small Businesses. I got a clip here from, I think, again, John Kennedy talking about the Joe Biden basically saying that if he is reelected, he is not going to renew the tax incentives that Trump put into effect. And he says that's going to be a promise that he makes. But it is remarkable that the White House now is trying to back up on that one, because it affects everybody in all different wage categories. We'll talk about that coming up with Leah at 8:05. More. But you better get it worked on. Delbert McClinton. Is that perfect song for that one?
I wish I had used that line when I was in private practice.
This is exactly. It may not kill you, but you better get it worked on. I broke my train of thought here. There was a couple of things I wanted to talk about. But first of all, it was the wrench that really tossed this out. When you're playing chess with this, looking ahead at the possible veto and all the numbers and have to do all the things that they have to do, was that Robert Johnson decided to use the Black Caucus as a leverage there, and that probably did more harm than good.
Yeah, it was definitely a curveball, but I have great respect for Chairman Johnson, and I've had lots of conversations about health care with him, and I know where his mind and heart is. I don't think they were trying to kill anything, trying to make things better, which is their prerogative. The problem was just wasn't time. And I really believe, Paul, if they had another week or so, that everybody would get to where we need to be comfortable with this session. And but I commend everybody that there was an awful lot of work done in a short amount of time, and a lot of strong leadership being shown, and health was very, very important this session in a lot of different ways. And Lord, it kept me busy. I know that.
Yeah. I wish we had a program, and hopefully this would have been one where we take those people who cannot afford it, not only get them insurance one way or the other, where it's not threatening the people who already have insurance, number one, but number two, makes them have some skin in the game. In other words, it just gives them an incentive to take that physical or that colonoscopy when they're supposed to, et cetera, et cetera. But in the long term, I think that's where we see the benefits.
Yeah, you're exactly right. And, Medicare is doing that. Medicare has wellness incentives that with their HMOs, they'll pay somebody $50 to go get their colonoscopy, $25 to go get the mammogram, and it's good health care sense. It's good health policy sense. When we get to things early and pick it up through screening, it's much less expensive, and we get much better outcomes. And I do think we need to do more of that in the Medicaid population. I desperately want to do that in the prenatal space to encourage women to get prenatal care early and stay on schedule. There are a lot of things that need to be done during the prenatal period and the postpartum period that impact survival rates for our Medicaid moms and their babies. And if a little bit of incentive helps them to do that, I'm all for it.
A lot of people look at this and they watch and hear about what's going on as far as the legislature, and they think we're just broken. Well, when you start looking at through history, we have the largest percentage of poor folks.
We do.
In a small state with a small number of earners. In other words, if you want to say the givers and takers, we don't have a lot of givers. We got a lot of takers, and it's just historically it. I mean, we're an agrarian society. We battle through slavery, the agricultural switch to industrialization, all of these different things, and we are where we are. And that's one of the reasons it just takes us sometimes longer, because the cards that we're dealt.
That's a fact. And there are advantages to being at the end of the line, because you're able to see what the early adopters did that didn't work. We will get there for our people. I just hope and pray that we will focus on the needs of people. We've taken advantage of the Affordable Care Act for insurance companies and for hospitals. We need to do it for people.
I want to ask you a couple of other things. As far as the medical marijuana, there was this legislation to increase the background checks. Is that still alive, or did that make it, or do you know?
Well, that died with the hemp bill.
He did die. Okay,
yeah. So that was to help public safety. Public safety has been, the FBI has been charging them specifically for the background checks. We actually do them physically. We have the equipment and the personnel that actually physically do them. and we charge the people that are getting the background check, but public safety has not been able to directly charge. So we were trying to work it out where Commissioner Tyndall would not have to keep eating those costs.
Ah. Now, I know you've been studying this when you probably don't have the full breadth of exactly what this means. I don't know if anybody does. The directives from Washington on relaxing some of the classification as far as marijuana. Have we seen what this is going to do to us?
It's going to do some good things, and then it's going to be some tricky things. But moving it to Schedule 3, if the FDA starts to approve medical cannabis for specific uses, and Big Pharma gets involved, then likely it's going to move from the dispensaries into the pharmacy as pharmaceutical companies are producing it. We don't know. But immediate advantages will be that the industry will be able to take advantage of business tax deductions, and they'll be able to be treated in the tax code the same as any other business is, which right now they're not. So they'll get some significant tax advantages immediately. And I think a lot of them built into their business models an exit ramp by selling to big tobacco or big pharma, whomever comes to the table whenever it did reschedule. We needed it rescheduled because we haven't been able to study it. And so when you hear people talking about the studies say there aren't any randomized, prospective, double-blinded controlled studies, which is what the FDA requires for safety and efficacy. We just don't have that because it's been illegal to do so. Now going to Schedule 3, Dr. Welch and the good team at Ole Miss at the National Center for Cannabis Research will be able to do legitimate.
They really step up in the importance on this, don't they?
Absolutely, and we plan to partner with them closely to get better data to see what works and what doesn't work.
I can imagine this would be in the form of the gummies or things such as that, not so much the smoking part of it as far as winding up at a Walgreens or something like that. But if that happens, they become, as you said, direct competitors, which means the retail outlets that people have invested in become a little less solid. Of course, the growers and everybody else probably are going to benefit from this.
I would think so. I think the dispensaries probably are the ones at most risk. But this is going to take a while. Nothing's moving to the pharmacies for years, but this is the first step.
Do you think we have enough study right now because they've been doing this for a long time, to go on and make some decisions on as far as the FDA is concerned?
No, sir.
To at least speed that up?
It will speed it up, absolutely. And it won't take long to get, I think, effective research, because there's some areas that we have seen just looking at the experience of medical cannabis where it's very, very promising. Yep. Like peripheral neuropathy is one, anorexia, chemotherapy, nausea. Those areas, I think, we'll nail that very quickly. And then I think you will see pharmaceutical-grade products going to market in those areas. But in terms of widespread, it'll take a while. And I'll tell you, in terms of all the qualifying conditions that are currently legal, we're going to see a bunch of those. It's ineffective, or but there's not significant data to support it. I mean, there are several things on that qualifying condition that's not there because of medical science. It's there politically, but we need data.
There are so many other things. We're about to run out of time, but I do want to ask you a couple of other things, and that's on the my mind just went blank here. On any other bills that are moving through that you want to talk about?
Well, no, we're very grateful that Public Health Authority was maintained, that our reauthorization statutes for the Board of Health and for State Health Officer were maintained. We were given a few more responsibilities that I'm actually excited about doing in terms of studying health care statewide. I'm very grateful that this year I didn't pitch the growing the agency or strengthening the funding of the agency. I pivoted towards making strategic investments in population health outcomes, such as maternal infant death and the emergency medical system, which is in trouble, and things like syphilis and congenital syphilis. And we were successful, not to the degree I would have liked, but I'm grateful for what we got. We've probably got about $3 million that we can invest specifically into those areas and make a difference.
Two more things I want to ask you. We'll do this real quickly when we come back as far as the onset of a measles outbreak in a lot of the schools where there are large portions of illegal kids who are in the schools now. I want to ask you about that. And also, any comments about 2799? Do you know if or if not the Mississippi State Department of Health is one of the boards inclusive in that? Quick segment next as we end it with Dr. Dan Edney. Right, we do see some outbreaks that are pretty large in some areas of schools where there are a concentration, like sanctuary cities, where there's a large concentration of illegal aliens coming in. But what's it look like here and in the surrounding states?
Well, gratefully, we've not seen a case of measles in Mississippi since 1992, and that's a direct result of excellent public health policy and solid state law enacting that policy that has kept us and our children safe for over 30 years from things like measles and diphtheria and pertussis and polio. What's very worrisome is that nationwide the numbers have been escalating, and it's really tied more to the anti-vax movement, Paul. Now, we do have cases where we'll have immigrants who are coming across the border who've not been vaccinated. But one of the first things that public health does is to get them vaccinated. But there are cases that come in and cause outbreaks. But we also see cases of unvaccinated, especially older teenagers, college students who come back from the developing world on a mission trip and they contract measles while they're there and bring it back, and there are outbreaks. That's what happened in Florida. We've had outbreaks in Florida just in the last year. Florida that spilled over to New Orleans, which really got our attention, and into Georgia. Florida did not respond with true public health science and used a little bit more political input in how they responded, and that outbreak grew and spilled over into our neighbors. Louisiana and Georgia jumped on it and contained their outbreaks with public health good policy and eliminated their outbreaks very quickly. We've had the big outbreak in Pennsylvania and then the most recent one in Chicago. So it's all over the place. And, Paul, this year we have had twice the number of measles cases nationwide that we had in all of 2023 already just through April.
Can you tell if we're having an effect here with the religious exemption in this state? Do you have numbers on that, or
we do.
Give me an idea?
We're between 2,800 and 2,900. We were with our medical exemptions. We ran about 500 children a year in the school systems that had medical exemptions, and that's the exemptions are up to close to 2,900, but the number of children in school this year are just under 800. So we don't have that many more kids in the school system. A lot of folks were just getting the exemptions for whatever reason, or they wanted to, try to avoid that MMR booster for freshmen that are going to college. Some of them just wanted to skip that last update at 7th grade. So right now we're okay. The main thing we're watching are pockets, and we have pockets certainly in the Madison County area, Lamar County area, down the Gulf Coast, and that really worried me with the New Orleans outbreak, but thankfully it did not spill over.
Are you or anybody predicting a new pandemic before the election?
Lord, if so, I'm going to the House. No, sir.
Speaking of going to the House before we run out of time, and we had Bobby Moody on yesterday, and it was good to talk with
I love
Bobby.
Mr. Moody.
He's an incredible guy. 2799 apparently passed out of the House. So my understanding, they made some changes in here. They cut a few of the boards that were going to be applicable to this. Was the Department of Health in there, do you know?
I haven't seen the last conference language, Paul. We were in it up until recently, but I know the public health committees of both the Senate and the House were against changing the Board of Health tenure and the tenure of the state health officer. And again, it won't impact me, but I care about how the system works. And boards like Board of Health, Department of Mental Health, IHL, it takes a while to learn that you come on these boards, it takes a few years to figure it out.
Of all the boards, I mean, it just takes a while.
And Board of Health is, I mean, our jurisdiction is so broad. We're talking about everything from keeping the water clean, keeping the hospitals open, running county health departments to hair braiding. So, the Board of Health members, it takes a bit for them to get up to speed. And they 4 years is not enough. We need it, and the Board of Health is not a problem. So don't mess with something that's not broken. Board of Health is a shining example of what works well in state government.
I have no idea what the governor thinks about this one, but it'll be interesting to see.
But we have until 2028 to really study it more and make some changes.
True. Anything else? Batting cleanup here. We've got a few seconds, but only a few seconds. Final thoughts.
Just to remind you and everybody listening that public health is public wealth, and if we want to be a wealthier community and economy, we need to be a healthier community and economy, and we're doing our job at the health department to try to make that happen.
And when you're driving by McDonald's, smell the French fries only. So that's it. Thank you, sir. Appreciate it very much.
Thank you, Paul. Always.
You got it. Leah Long, after news, coming up next.
What I find is pleasing.